Good morning. Today we will discuss two all-round scenario one on renal injury, one on urethral injury. Will be presented by Dr. Shubham, who is a second year junior resident at Calcutta National Medical College and now at DRP at MR Bangalore Hospital. And with us today will be Professor Devanshu Sarkar, he is Professor of Urology at IPGM and SKM Hospital. So Shubham, you can share the slide and you wait for the question to be asked by Dr. Sarkar. So first scenario is this. Yeah, just read.
Good morning, everyone. Good morning, sir. We have a case scenario, which is a 40-year-old gentleman presented to emergency following RTA with complaints of pain abdomen and loin pain with swelling on the left loin and hematuria. So how will I proceed? Okay. Sir, first...
Just let Dr. Sarkar ask how we want to go with the scenario.
Okay, so this is a typical scenario where you find patients in emergency with history of trauma. So what are the specific histories you will ask in this patients which is important for your management? And after that, what are the specific things you will look for any genitourinary trauma? History?
Sir, first I'll approach this patient as per ATLS protocol. I'll look for first airway, then breathing, then circulation, and then in disability, and every parameters are managed. Then I'll go for the history. I'll first see the mechanism of trauma, mechanism of injury, that how what kind of injury has occurred first, and second, patient is having complaint over which specific reason in abdomen, and whether there is any, and then I'll examine the patient whether there is any abrasion or laceration or any wound over pelvic region or loin region.
No, don't jump. Dr. Sarkar, say history part. You just say mechanism injury and the pain
and
part.
The pain part.
There are a lot of things in the history to be asked to, because you don't take it as just a renal trauma, just because it's a what scenario.
Yes, yes, yes,
take it as a composite trauma and give us the details of history, what you should ask.
Sir,
you have talked of the mechanism of injury. Second,
yes,
you talked of the site of pain. What else?
Sir, the other complaint patient may have will be
this already has a swelling in the loin and hematuria. So what do you like to know about this?
Sir, first I'll like to know that where was the impact of injury, and whether it is where the patient hematuria is there, so patient is able to pass urine. And history part is
over. Why? You see, this is a patient who has got such a severe injury, which is swelling in the loin. He might have other abdominal injuries.
Yes, sir. I'll look for pain in any other abdominal region, any other symptom, whether patient is having other complaints.
Like
patient,
can this patient have acute chest injury?
Yes, sir, definitely.
Then
patient can have rib fracture on the.
If you are asked about the history part, try to give any comprehensive points in history about this particular injury and to exclude other associated injury.
Yes, sir. So I'll ask for pain or other complaint. I'll ask whether patient is having difficulty in breathing or patient is restless, and other.
What are the other injuries you are concerned of?
Sir, there may be associated pelvic injury. There may be associated rib fracture on the ipsilateral or contralateral side.
Yes.
There may be associated injury to the other organ like liver or spleen, since patient is having pain left side. So I'll suspect patient may be having injury to spleen.
The patient might have head injury, the patient might have spinal injury, patient might have limb injury. Yeah. So you have in a patient, you are right that whenever a patient comes to the emergency, first thing you should look for a ATLS protocol. That is fine. And that is a must in all trauma patients. Once you are sure that the patient is stable, you can get some histories. And so there are two things as Shah sir said, the first is you are concerned with the whole patient. What are the other injuries, and ask the respective questions for other injuries. And after that, you come to this particular injury. Don't jump to this particular injury. Patient may be having a severe injury elsewhere. You are concerned with the renal injury. Okay, fine. So coming to this particular patient, there is no other injury, and you are suspecting the patient is having a genital injury. So what specific history will ask?
Sir, the history part, after mechanism of injury, is patient is having pain and swelling, and then he's able to pass, and he is having hematuria. So,
anything in the swelling is important.
Yes, sir.
We said swelling.
Yes,
So
sir.
anything in the swelling is important.
Sir, what was the onset of swelling? Whether it is progressive, whether it is associated with any visible pulsation, or it is expanding. All these points I'll look for.
Okay, one thing you should always ask is what was the time of injury? Suppose the patient had injury day before, 18 hours before, and how was he or she was resuscitated in other hospitals? What is the amount of fluid, if it is possible? Because sometimes you will see the bladder is not purple. So you are not sure whether the patient has a bladder injury or the
it is
patient
not
was
resuscitated, is not
properly.
yes.
Yes, that is very important. Was the initial injury and what the patient properly managed, because you need to differentiate between a bladder injury versus a acute tubular necrosis or acute renal failure. Okay.
Yes.
Okay. Fine. So, salient points in clinical examination in renal trauma.
Sir, first I'll look for, is there any laceration or abrasion or some injury over the loin, or overall I'll expose the patient and I'll look for any visible injury. As there is swelling, so where is exactly location of the swelling? And after that I'll go for palpation, whether I'll examine the swelling, whether it is tender, and that I'll look for the vitals. If patient is vital, what is the general condition of patient? If patient is unstable, then what are the pulse rate, BP, saturation?
See, any trauma, the first thing is his vitals, ATLS protocol. All this examination and history parts comes out after that. Okay, you have taken care of that part before. Okay, so you look for the swelling, you look for the palpable bladder, you look for any telltale sign of any pelvic injury or bladder meatus. So what is the importance of a palpable bladder in this case?
Sir, bladder is palpable, so there might be injury to the urinary tract, or
where
sir, in the urethra.
Yes.
Or patient may be having some neurological injury, spinal injury, which might lead to some loss of autonomous control. That may also be
more common.
More common, sir, injury to the urethra. Maybe patient may be having associated pelvic injury, and the trauma to urethra may lead to palpable.
The patient not having urethral injury still have a palpable bladder. More common.
Patient again hematuria.
Sir, bladder injury leading to, sir, hematoma and.
No. Patient is having gross hematuria and he's having clot retention.
Oh,
that is more common. Severe renal injury, gross hematuria, clot retention. Okay. So it can be clot retention, it can be associated with urethral injury.
Try to take the lead. Dr. Sarkar is saying there is no urethral injury. Still bladder is palpable.
So there may be obstruction to the urinary tract.
Okay. What next? You have ruled out other injuries by clinical examination. What next?
So next,
so what is your suspicion at this stage?
Sir, at
patient is having hematuria, partial urine.
Patient is having, sir, injury to kidney. Kidney
so you suspect renal injury.
Renal injury, and I'll resuscitate the patient. And if patient is stable, once patient is stable, I'll go for some investigation.
Investigation? What investigations?
Sir, first I'll go for USG, first EFAS to look for other abdominal injuries, and after that USG over the kidney ureter bladder region, and after and then since patient is having hematuria, I'll go for CT.
What CT? Plain CT?
No, sir. Contrast enhanced CT with delayed phase.
Okay. So what is the usual picture in ultrasonography? Tell me first. What do we expect in ultrasonography, and why do you need a CT?
Sir, because
First ultrasound. What is the lead in ultrasound in a patient like this, as a swelling in the loin, suspected renal injury? What you can see?
Sir, there may be associated hematoma around the kidney, and kidney might not be visible properly in the ultrasound. And what exact injury has occurred, we will able to
anything else in ultrasound? Okay, one thing is there may be some perinephric hematoma, or kidney may be shattered, there may be associated other injuries, there may be intra-abdominal fluid collection. Okay, these are all things. You do not confine yourself to the kidney only. You should look for other injuries also. Okay, fine. Anything else other than hematoma? You can
in ultrasound, can you make out that cortical outline in a normal kidney?
Sir, yes, sir, corticomedullary differentiation we can see in the USG, which will
in a normal kidney.
What
can happen in a
sir, it won't be, sir, demarcated. Kidney having, since there is trauma to kidney, we will not be able to see properly the medulla and the cortex. And then if there is the injury like ulceration to the kidney, it will be.
Ultrasound may not give you an exact grading of the injury, but at least in ultrasound you can make out that yes, there is hematoma, the cortex appear to be breached. So there is some lead in ultrasound.
Okay, and one thing you can do is you can do a quick Doppler to know the vascularity, whether this is a vascular injury, major vascular injury or not. Okay, that is another advantage of doing a ultrasound. Okay, fine. CT. So why do you want to do a CT?
Sir, main aim to do CT is to look for any vascular injury and to see the contrast extravasation.
Apart from that, can CT give you an idea about the functioning status of the kidney?
Yes, sir. Since contrast will be since we will see the contrast will pass through the kidney, it will give idea to the kidney functions.
Okay. Just a theoretical questions. Can you tell me what are the indications of doing a CT? All renal trauma patients all abdominal trauma patients does not need a CT scan.
CT scan,
so
yes.
Pertaining to this renal injury, what are the indications of doing a CT?
Sir, in case of renal trauma, we'll go for CT when patient is having gross hematuria, or patient is having microscopic hematuria with shock, or in case of pediatric patient, even if patient is having microscopic hematuria, we'll go for CT.
Anything else?
If you're having a perinephric hematoma, you need to do CT?
Yes, sir. In case of swelling which developed after trauma, we'll go for CT.
Okay, there are two things. One is you have not done any USG, not based on clinical findings. Without doing a USG, you can also do a CT scan in this situation. Patient gross hematuria with hypertension. Pediatric patient, you have done routine examination, find more than 5 RBCs. Okay, or if you find any penetrating trauma, particularly to the loin. Yes, that is an indication you can directly go for a CT also. Okay. Okay. So you said that you will advise a contrast enhanced CT scan with a delayed film. So yes. Why a delayed film?
Sir, delayed phase to look for any injury to the collecting system, or to look for injury to collecting system, or yes. Any urinary extravasation.
Yes, that is a very good thing, that whenever you advise any CT scan in a patient with suspected renal injury, you have to have a delayed film, otherwise the investigation is incomplete. Because one of the ideas, by doing a USG, you know the patient has a renal injury, but you need to know what is the type of injury, what is the grade of injury, particularly whether this has a significant extravasation. To know that extravasation, delayed film is a must. Okay. Yes, so what are the things in different phases of CT scan what are the things you should look for? Can you tell me what are the phases of CT scan in renal trauma?
Yes, sir. Sir, phase of CT scan, sir.
Yes.
There are 4 phases, sir. Pre-contrast phase, arterial phase, and venous or parenchymal phase, and then 4th one, relate phase.
Venous and parenchymal are not same. Venous is parenchymal is quite early. Parenchymal phase doesn't come with the venous phase. Venous phase is a little delayed phase.
Okay, sir. First pre-contrast phase, then
Okay.
arterial
In
phase.
pre-contrast phase, what do you see?
Sir, we see if there is any.
What you can see in
sir, normal anatomy of the other side, and what is the difference, and to compare it with the contrast film.
What you can see? You can see the kidney outline will be enlarged.
And this is distorted. There will be shape, normal shape will be distorted. There will be some swelling, whatever it is, hematoma, or it will be visible.
Okay.
Hematoma can be seen even in a plain film.
Plain film, it will be hyperdense.
Okay, and sometimes there is an associated stone also. You can see that sometimes the patient has a contralateral stone disease. So that is seen in pre-contrast. What do you see in arterial phase? Where it is important?
Sir, to look for arterial extravasation, and if there is associated severe injury like renal pedicle avulsion, so it will be grade 5 injury.
What can happen?
Sir, the patient will be having extravasation of the dye without enhancement of kidney.
Grade 5, you'll see the kidney at all?
No, sir. Sir, we'll just see the extravasation going to the hematoma, and kidney will be not enhancing.
Yes, there can be two or three kinds of things. One is the patient has a peripheral vascular injury. Okay. In that case, you see a non-enhancing part of the kidney to the site of injury. And sometimes you might see a perinephric hematoma also, which is actively bleeding. Okay, you can see arterial contrast in the arterial phase. Okay, that is in patient who has peripheral injury. In case of pedicle injury, two things happen. Sometimes there is complete avulsion and the artery goes into spasm. You might see some old clot in the medial aspect of the kidney, in the pelvis, and the whole kidney is not enhancing at all. Or sometimes there is intimal injury leading to a thrombosis. In those cases also, you will not see any extravasation, but the kidney will be non-visualized. So 3 things. If there is peripheral injury, hematoma laterally, and non-visualization of that part of the kidney. If there is pelvic injury, pelvic or hilar injury, if there is contrast extravasation, you think the arterial injury leading to extravasation. If there is intimal injury, no contrast extravasation, but the kidney is not visualized. So that is very important. Okay. So what happens if there is venous injury?
Sir, there will be no contrast extravasation in arterial phase, but there will be contrast extravasation in the venous phase.
Okay. So what do you see in delayed phase?
So delayed phase, we look for contrast extravasation through the collecting system, through if there is any extravasation or medial or over medial or lateral region. If there is contrast extravasation from lateral extravasation, that means there is injury to pelvic-axial system, and if there is medial extravasation, that means injury to uretropelvic junction.
Okay. So is your concern changes if you see a lateral injury versus a medial injury?
Sir, if there is medial injury and
2 patients, one
yes,
you
sir.
see there is huge collection of contrast lateral to the kidney in the perinephric space versus a patient who has moderate amount of contrast extravasation, which is close to the pelvis. Are these 2 patients same or different? Okay. What is the difference?
Sir, in case of medial, if it's extravasation, we'll look for contrast going to ureter. If it is not going to ureter, then patient will be requiring immediate exploration. In other case, we can go for conservative management if patient is stable, hemodynamically stable.
Okay. Yes, if you have medial extravasation, you have the suspicion of renal pelvic injury.
Yes.
And it's not a blanket statement that all cases of pelvic injury need exploration. Initially it was there, now it has changed. But yes, if you cannot find any contrast in the ureter and there is, you do not think that the extrinsic compression because of the contrast or urinoma is compressing the PUJ, you think that there is chance of PUJ avulsion, that is an indication of exploration. Okay, so any kind of medial extravasation of contrast in the delayed phase is be very careful. So what is the exact cause of this extravasation? Okay.
Injury to uretropelvic junction or pelvic injury, injury to pelvis.
Yes. And sometimes in delayed film, you might see some unexpected ureteric injury also. Because most of the cases are deceleration injuries. If the patient has associated spinal injury, these patients are prone for ureteric injury also. So in those cases, you should try to look or trace the whole of the ureter, look for any ureteric contrast extravasation. Okay. So can you see the CT of this plate?
No, he's not there. Just a discussion.
Okay. So suppose this patient is explored for, tell me, what are the indications of exploration in renal injuries?
So in renal injury, if patient is unstable even after resuscitation. Second, if there is injury to pelvic alicil system. So no sir. If there is renal.
If you go by grade,
sir.
If you go by grade, which grade of renal injury might require?
Sir, grade 4 or grade 5 injury might require if patient is unstable. If there is complete injury to there is pelvic-ureteric dissociation, then patient will be needing exploration. And
patient requiring exploration for other internal pathologies. Yes. That is another situation that you are having a free gas in the diaphragm. So you such a hollow viscous perforation or any other abdominal injury which require bandage laparotomy.
Yes, sir.
See, there are two situations. One is when you decide your exploration based.
You are not.
Disconnected. You are present or Dr. Dr. Sharkar got disconnected. Just continue, just a minute. Yeah. Yes, Dr. Sharkar, you are back. Dr. Sharkar, I can see you, but you are not audible.
Hello?
Yeah, you're audible, please.
Sorry, I got disconnected.
Yeah.
So there are two situations. One is based on the clinical scenario, you need to explore. That is, if the patient is hemodynamically unstable, you do not know what is the cause. It can be renal injury, it can be liver injury, it can be a major vascular injury. That is one indication. Second is, if you find any penetrating trauma to the loin, whatever may be the findings, you need to explore. So these are the clinical situations you need to explore. Third situation is somebody else has explored for other injuries and you are called during the operation if they find any perinephric hematoma. And fourth situation is on CT scan, there is some indication they need to explore this kidney. The fourth situation is if you find a grade 4 or 5 trauma, whether the patient is hemodynamically stable or not, hardly matters. So these are the 4 indications of exploration. Okay. So coming to that situation, where your general surgery colleague has called you intra for other injuries and they find a hematoma on the right perinephric space, what will be your approach?
Sir, first I'll examine that whether the hematoma is expanding or it is expansile. If not so, I'll not disturb the hematoma.
Very good. So it is an expulsal hematoma. Then
So then we'll have to explore and we'll we'll open the Urethral fossa and then we'll see what is the injury.
so you'll first open up the Gerotus fascia.
So no, sir. First, we'll look for if there is in midline is visible. So then we'll look for inframesenteric vein, and then we'll give incision, and then we take the control over of renal vessels, both artery and vein. Then we'll go for open the fossa.
So you should never disturb the perinephric hematoma in case of renal trauma, whether this is an emergency exploration or this is a planned operation. The first intent of your exploration will be to take control of the renal arteries, which you have told inframesenteric vein, give a vertical incision and go to the root of the arteries on the left side or right side. That is very good. Okay. So what do you explain or take consent from the party before going for an exploration in case of any renal trauma?
Sir, we'll take the nephrectomy consent.
Yes, that is very important.
Yes, the patient might require nephrectomy during exploration.
Yes. Okay. Sir, anything else in renal trauma?
We can ask a little about the grading of injury that is often asked.
Okay. So can you tell me the grading of injury and what is the importance of this doing this grading, CT grading?
Sir, coming to grading of the injury, there are 5 grades of injury. Grade 1 is subcapsular hematoma without any laceration, and grade 2 is less than 1 centimeter laceration of cortex or perirenal hematoma. Third, grade 3 is more than 1 centimeter laceration, not extending to the medulla or collecting system. It's grade 3. Grade 4 is vascular injury, any renal vascular injury or laceration reaching up to collecting system. Grade 5 is the complete either complete avulsion of the renal pedicle or shattered kidney.
Okay. Yeah. So how does this grading helps you in management?
Sir, if we are suspecting some severe injury and there is on CT grade 4, grade 5, it helps us to guide to the treatment.
Grade 1, grade 2.
Conservative management. Yes. Sir, it helps in the management.
How?
Sir, if patient is having grade 1 or grade 2 injury, we'll go for conservative management. If grade 3 injury...
With grade 1, grade 2, patient is unstable, patient has some abdominal signs. What do you think?
Sir, we will suspect some other injury.
Yes. Yes. In spite of grade 1, grade 2, and find the patient is unstable, patient has other abdominal signs, one should consider the other pathology.
Sir, you are not visible.
Hello.
Yes, yes.
Yes, sir.
Grade 1, grade 2, you said that conservative and other injuries might dictate laparotomy. And I think we should discuss what should be done on exploration. Even in a grade 3, 4 injury, what are going to do on exploration? What is the principle?
Sir, principle is to look for take the control of ongoing hematoma.
Principle is conserve renal tissue. Is not a situation that you like a spleen, you'll go for splenectomy. Here is idea is to conservation. So how do you do that? You have grade 3, grade 4, grade 5 is a very bad situation.
Yes, sir. Sir, we'll go for partial nephrectomy if patient, if possible.
See, the conservation is the motto in any kind of renal injury. Okay. So if it is grade 1, 2, 3, and if the patient is not having active hematuria, don't do anything. Just do conservative therapy, because most of the cases, if you explore in case of renal trauma, ultimately you are going to land up with nephrectomy. Okay. So the first thing is you should have an adequate drainage of the kidney. For that, you should have an intact PCS system or any drainage. Second thing is you need to control any bleeding if it is there. These are the two mottos. So earlier the concept was, if the patient is bleeding heavily, you explore and control the bleeding. Now with the advent of this digital subtraction, angiography and angioembolization, most of the cases, even if the patient is bleeding heavily, do not need any exploration. You can do a renal angiography and do a selective angioembolization. Okay, this is for the bleeding part. For the pelvic exploration, earlier it used to be exploration and repair of the pelvis. Now what we do, either we put a digestion from below or we put a PCN from above. Okay, your idea of doing exploration was to close the PCS. That you can do with a digestion and PCS. So in exam, if you are asked, what do you do in a patient with pelvic injury? You can say that, sir, I'll look for what is the grading of pelvic injury, the severe injury, all the contrasting going outside with a complete disruption of the PUJ, pelvic junction. Yes, you have to open up and repair, but if you can find any, suppose the injury in the pelvis not at the PUJ, okay, there is a continuation of the pelvis, PUJ. You can put a digestion and wait how the patient behaves. Wait for its any extravasation, wait for any sign of fever. And if you can see the patient is, most of the urine is going through the digestion to the bladder and very minimal or leaking, you can do a conservative treatment in this patient also. So the management is operative, but not open operation. Okay, you can do minimal surgery by a PCN or a digestion in case of pelvic injury, or in case of peripheral vascular injuries where you were initially opening up the patient for doing a partial nephrectomy, you can just do a angiography and selective embolization. Okay.
Yes, sir.
And if you have to open, the first thing is you have to take control of the renal artery. Never ever open up the aorta. What will happen? The patient is having a confined hematoma. Patient is hemodynamically stable. If you open up the aortas, this compartment will go and the patient suddenly develop more
ongoing bleeding
and bleeding. Okay.
Yes.
So take care of the vascular pedicle first.
Yes.
Okay, we can pass on to the second scenario, urethral injury. Yes.
Okay.
Yeah. Read.
A 20-year-old male patient sustained pelvic injury following a road traffic accident. Patient has been unable to pass urine after the accident. How will you proceed to manage this patient?
Okay. So I'll not ask you anything about the ATLS protocol, all those things. So
Yeah, we have discussed this.
Yes, straight away come to these patients. So specific histories you should ask in this patient, and specific things you should look for. 1, 2, 3.
Sir, first the mechanism of injury. Second,
Okay.
if I'll look whether since patient is not able to pass the urine, I'll see whether there is any local laceration or injury. I'll look for the blood at tip of meatus, and then third thing I need is the two-step. If there is pelvic injury, I suspect pelvic fracture, then I'll stabilize the fracture and then proceed.
So one by one, mechanism of injury.
Sir,
How it is important?
because if patient is having some severe injury, with fractured pelvis, such huge injury, then we'll definitely suspect injury to the urethra or adjacent structures like bladder or blood neck.
Okay, two things you should ask in mechanism of injury. What is the severity of injury and what is the type of injury? So
Yes.
a patient who is falling from a 2-story building will have a different kind of pelvic injury from a patient who has a head-on collision anteroposteriorly versus a patient who was hit by the side. So these three kind of injuries produces three different kinds of pelvic injury. And all these patient kinds of pelvic injury has different kinds of urethral injury and associated neurovascular injury. That is important. If a patient falls from height, he has a vertical shear injury leading to a pelvic nerve injury associated. So that is very important. If you go, if you look very next time, whenever you go to the emergency, you ask this history to the patient and look for the type of pelvic injuries. You will find the difference. Anterior posterior injury, lateral injury, and vertical shear injuries. Okay, so that is very important. When you next we will discuss about the retrograde urethra, we'll see what is the difference. Okay, that is one thing. Second, you forgot to mention, I mentioned before also, was the patient resuscitated or not? This is very important because sometimes some patients will have a urethral injury with an associated bladder injury. Unless you take the history of resuscitation, you never know whether the patient is having a retention or whether the patient is not resuscitated properly, having anuria, or whether the patient has an associated bladder injury. That is the reason the patient is not having a palpable bladder. He's having a urethral injury, but since the patient is a bladder injury, you are not getting any palpable bladder. It can be misleading. So this is very important in a patient with suspected urethral injury. Resuscitation history. Okay. Then examination bladder meters. Anything else?
Sir, we'll look for the bladder, whether the bladder is palpable or not.
Perineum.
We'll look for perineum and the penis external meters.
Yeah.
Yes, sir.
You said you stabilize the fracture. Does the fracture stabilization gets priority over the other part of the management?
Sir, first and foremost, I'll resuscitate.
Resuscitate and
then we'll look for any. Then
see, the prevalence of the pelvic fracture comes late. Vital stabilization, addressing the urethral or bladder injury, and then comes you have a plain X-ray, agreed. But if there is a fracture in one of the pelvic ramas, that does not get priority over your other management.
yes.
Okay,
Yes.
so fracture stabilization comes last. Rashaka, you are not audible.
Hello.
Yeah. Yes.
So what next? So you have, the patient is hemodynamically stable.
Yeah.
And you have a strong suspicion the patient is having a urethral injury on the basis of a palpable bladder and bladder meters. What next? You are working.
He has the urge to pass urine. What do you say?
Sir, if he has urge to pass the urine and he is not able to pass the urine, then I'll suspect the bladder injury. I'll suspect
No. Bladder is full.
Sir,
but still he say I'm trying to pass urine. What you will tell him? You will encourage him to pass urine or ask him to wait?
No, sir. I'll ask him to wait.
Why?
Sir, because if patient may be having extraperitoneal bladder rupture, in that case, patient has urge to pass the urine, but patient is not able to pass.
Is that? Okay. Yeah.
Sir, this is controversial regarding asking the patient to pass or not. There's a lot of debate. Okay. For general surgery, yes, they should say if the patient has a palpable bladder and bladder meatus, patient.
Okay, fine. But that was the easier teaching. Now, so what should the strategy in this situation? Patient has a palpable bladder and is not passing urine. What should be done next?
So this patient has a strong suspicion of urethral injury.
Yeah.
So even in urology, there are two schools of thought. One school says that if you are suspecting injury, do not catheterize the patient.
Yeah.
And one group says yes, a gentle attempt taking all aseptic precautions should be tried. So better answer is, if he is working in a tertiary care hospital where he has a facility of emergency ascending uretrogram or RGU, it's best to do RGU if the patients can be moved or if there is no unstable fracture. The first thing they should answer is, sir, I'll do an X-ray and look for the stability of the fracture. If the patient has a stable fracture, I'll subject the patient to emergency retrograde uretrogram.
Yes.
So here the importance of retrograde uretrogram comes. So why should you do and if he's working in a center where there is no facility of emergency RGU, then the answer should be yes, sir, I will try a gentle catheterization, single attempt taking all precautions. And if I find any difficulty, I'll not push. If the catheter goes very easily, fine. Otherwise, I'll not push. I'll put a space in this patient. Okay. So if he's working in a tertiary care center hospital, he should say, I'll do a X-ray, look for the pelvic stability, stable fracture. I'll do a retrograde. Okay. So can you tell me what you see in RGU? What do you do emergency RGU in case of pelvic injury?
Sir, to look for what is the
You understand?
Yes,
You understand what is RGU?
Yes, sir.
Where do you push the contrast?
Yes, sir. To look for the contrast.
Where do you push the contrast?
Via the meters.
Yes. So you push the contrast through the external meters.
Yes.
So what are you looking at?
Sir, we are looking at the urinary tract, whole of urinary tract.
You cannot see the whole of urinary
Sir,
tract.
not exactly, sir. We are looking at the urethra and the bladder.
Yeah.
Lower urinary tract. Sir.
Yeah.
So what information you get?
Sir, from there we see whether there is extravasation of the contrast via the bladder or there is any disruption of the urethra. We can see. Sir.
One situation is urethra is seen, bladder is not seen.
Yes, sir.
What is the situation?
Sir, that means there is complete reception of the urethra at most probably at membranous part in the membranous part.
So that is one. Second is extravasation, but still bladder can be seen.
So extravasation from where? From the urethra.
From urethra,
Oh,
but still bladder is
So that
visualized.
means partial injury to the urethra.
Yeah.
So how this is helping you in management?
Sir, if there is intact urethra and there is no bladder extravasation, we can try catheterization. And if there is the discontinuity or the bladder is not as said that there is no contrast in bladder, so in that case I'll not try for catheterization, I'll go for the species.
Yes, the idea of doing an emergency RGU is it will help you managing the patient.
Yes.
If you find this is a type 1 injury, there is only stretching injury,
So
you can safely catheterize.
yes.
If you find the patient has a partial injury, contrast is going to the bladder and you can see the urethra. At the same time, there is some extravasation. So you can try a gentle catheterization. If you find a complete disruption, there is no communication with the urethra with the bladder, do not attempt any catheterization in this patient. Okay. And the fourth importance of this during an emergency RGU is sometimes there is an associated bladder neck injury, which is not possible to diagnose clinically based on your clinical examination. So if you find a patient who has a associated bladder neck injury also, that is an indication of emergency exploration.
Yes.
So in that case also, you are getting some information from this RGU. So this is how a RGU helps in emergency. Okay. So can you tell me the classification of urethral injury? What are the classifications you know, and why this classification helps? How this classification helps?
There is grade 1, 2, 3, 4 and 4A. What's the exact I cannot remember. Okay.
Which classification you are telling? You know, at least tell one or two classifications.
The
Name.
Name I don't know, sir.
Okay. So okay, there are mainly two classifications. One is AAC classification, one is Goldman Polar classification. And one is based on the continuity AST classification, whether this is no injury versus partial injury versus complete injury. And this Goldman classification based on what is the type of injury or site of injury, whether this is have the pelvic diaphragm or below the pelvic diaphragm, whether this is only urethral injury, whether this is urethra plus bladder injury. This is more important in case of management, this Goldman classification. Okay. So if it is a complete disruption or partial disruption, you could not catheterize the patient in case of partial disruption. So what next?
Sir, if catheterization is not possible, so I'll go for suprapubic catheterization.
Okay, suprapubic catheterization. So can you tell me the steps? Tell me the prerequisites of suprapubic catheterization and the steps.
Sir, first the bladder should be palpable, full. It is done in full bladder,
Okay.
and yes, sir. And after that, I'll go to the steps. First, antiseptic dressing and push the local anesthesia over a region where I'm going to make incision. Incision will
What
be
is
made.
the site of your incision?
Sir, incision will be made midpoint between the umbilicus and upper margin of pubic symphysis.
Excellent.
Yes.
Why?
Sir, because if I'll put the incision on the where we usually do in the lower part, then it will be, sir, when patient will be undergoing further urethroplasty, it will be difficult. That's why, sir, we do above.
Okay, excellent. You are answering like an FCH resident. Okay,
Yeah.
fine. So that is very good. Frequently, we get patients who has a SPC very low down. It's very difficult for us to do a suprapubic inspection. Spectroscopy is very difficult. So it's always between the midpoint of symphysis pubis and umbilicus. Okay, fine. So
And
you
this
have
is
put
what,
the,
open or
Sir,
trocar?
trocar with trocar.
Yeah.
what will be the direction?
So direction, I'll be inserting the trocar almost 45-degree angle with at 45-degree angle, and it will be directed towards pelvis.
Yes. Why not vertical?
Sir, because if I'll go vertically, I might injure the posterior wall of the bladder.
Yes, it should be roughly 45 degree.
Almost, yes, sir, almost 45 degree.
Okay, fine. So you have put the patient on SPC. What next?
Sir, now I'll do conservative management, and then we'll look for any other injuries. I'll
Done.
manage. Sir,
Only
everything,
injury, SPC gone home.
Yes,
What
sir.
next?
Sir, next, I'll wait for at least 3 months to get inflammation subside and will get urethra.
Can you tell me any condition where you need to explore immediately? Suppose this patient
Yes,
comes
sir.
and you do a RGU and find something on RGU which or in clinical examination who tells that the patient needs immediate exploration.
So immediate exploration, there are some indications like associated bladder. In case of associated bladder neck injury,
Yes.
if there is associated rectal injury, or there is a bone which is inside the bladder, or it is impinging over the bladder neck, in that case also we have to do immediate exploration.
Yes. These are the 4 indications you need to explore immediately. And in case of female patients, sometimes the patient has a associated vaginal injury, you need to explore. Okay, you cannot manage this patient conservatively.
Yes, sir.
Okay, so 2 ways. One, you can put the patient on SPC and call him after 3 months, or anything regarding immediate or delayed repair, always you have to wait for 3 months.
Sir, I cannot understand the question.
No. Is it a question of always a delayed repair? There is some areas to consider for early repair.
Sir,
You see, there are a lot of discussions earlier that one can go for immediate repair.
Yes, sir.
And versus that early repair.
Sir, early repair. Exactly. So what I know is if we previously used to go for primary anastomosis, but that has some complications. That has some complication like urinary incontinence and impotency. So now it is preferred to go for delayed repair.
Okay, So if you're asked regarding this, initially you tell, sir, normally we do SPC and call the patient after 3 months for definitive repair. But if the examiner asks anything else, yes, sir, we can do a delayed primary repair after 48 hours, between 48 to 14 days. Why? The patient is stable, the fractures are stable, and in that case, you can do a primary realignment, endoscopic realignment. What you do, you pass a flexible scope through the suprapubic root and a passive scope through the urethra. And by this, you try to pass a guider either from below up or from up below, and try to put a catheter. It has been seen, if you can do this, you can put a catheter through the urethra in the immediate setting. This leads to less chance of stricture formation, and even if the stricture is formed, the severity of the injury, at least the distraction is less. That is the thing. Okay. But the role, what you are telling, that immediate open exploration is not there, because yes, the chance of high incontinence and impotence is not there. So in exam, you tell, sir, I will call the patient after 3 months. If the examiner insists, then only tell, yes, that is there is an option of delayed endoscopic realignment. It's a term, delayed endoscopic realignment. Okay, this is not a repair. This is realignment for future repair. Okay.
Yes.
So I think this is
yes. This is enough for a student. Yes, all right. Thank you.
He has answered very well. Very well. Well done.
Thank you, sir.
Thank you. Thank you, Dr. Shankar.
Thank you, sir. Thank you.
Thank you.
In my